Bismillah ar-Rahman ar-Rahim. Dr Hamza Alsayouf, Consultant Pediatric Neurologist, American Board. Today we are going to continue our epilepsy series in children, and today it would be an episode about what do the families expect when they go to a pediatric neurologist. So when I go and I take my son with a history of seizure or an event that is suspicious for seizure, what do I expect from the neurologist or the child neurologist that would be done for my daughter or my son? First, I do expect that my child neurologist or pediatric neurologist will take a thorough history, just like any other disease in the world. Thorough physical examination, that he will touch about the developmental history, if the kid is developmentally normal or not, and take a detailed history of the event, and if the event looks convincing or suspicious to the doctor that it might be a seizure, this is based on the experience, then I do expect that an EEG or electroencephalogram to look for any extra electricity in the brain, or focal sharp wave generalized epileptiform discharges, what we call it in the lay language, extra electricity in the brain. 24-hour EEG might be requested in some cases, like for example, an event that happens multiple times a day and it is not a clear cut for me that that's a seizure. Then I would move to a 24-hour EEG to make sure I catch the event, and I make sure that this event is actually a seizure before I start the medication. I also do expect to order an MRI of the brain. Yes, CAT scan is brain imaging, but there is a major differences between the CAT scan and the MRI. The CAT scan is good for acute injury. It's good for blood calcification. It is not good to look at the posterior part of the brain, and it is, as I usually tell the families, as if you are using 1 megapixel camera made in 1990, and MRI is great for looking at the brain substance. It has multiple cuts, and it also give details much more than the CAT scan, as if you are using an let's say 250 megapixel camera that is made in 2020. So there's a big difference. So I do expect to get MRI of the brain in the overall and in the vast majorities of the epilepsy, except in some kinds of epilepsy. And after that, if it is the first episode and the EEG looks normal and it's convincing to be that this is an epilepsy attack or seizure attack, usually we would delay the treatment for the second attack. If the brain EEG is very abnormal, or if it fits with certain types of seizure, then I do expect the patient to be started on medication. I do expect my pediatric neurologist or child neurologist to give me by the end of the evaluation if this is a seizure or not. What kind of seizure? Is it partial, or is it generalized, or is it specific kind of seizure like infantile spasm, absence epilepsy, and so and so. And we also do expect, when we get started on medication, what are the side effects of the medication, how to titrate the medication, what should I do when we have some side effect, and also how long we are going to use the medication for, and when do we wean off the medication, and the emergency plan. What should I do when the patient starts having a seizure, especially in the generalized tonic-clonic seizure? Usually we give rectal diazepam or buccal midazolam. If the seizure lasts more than 5 minutes to abort the seizure, then take the patient to the nearest hospital, as we have explained in the previous episode. And I do expect a regular visit to the doctor every 2 to 3 months. I don't expect that the doctor will get MRI every time I visit the clinic, except in rare circumstances. EEG is usually done at the beginning of the seizure to diagnose the seizure. Then when I want to wean the seizure, the indication to repeat the EEG is frequently is limited if I am looking for normalization of the EEG, like in case of infantile spasm, in case of absence epilepsy, in case of electrical status epilepticus in sleep. These are kind of seizure that we need to get repeated EEG to make sure we normalize the EEG, but by vast majority we don't need to keep repeating the EEG. Now, remember the EEG, we are looking at the electricity. The MRI, we are looking at the brain itself, like a video. The sound is the EEG, and the pictures is the MRI. So they both are complementary to give me, a full picture of the patient event. Now, remember the EEG does not have to be an abnormal to be diagnosed as epilepsy, because epilepsy or seizure is a clinical diagnosis. EEG aids in diagnosis and it helps in classifying the seizure, as well as it helps also on the prognosis, because if sometimes it tells you what kind of seizure and what's the prognosis. Remember, if the event is not a seizure and the EEG is abnormal, you need to put in a clinical context. Is this seizure is this attack fit with this EEG abnormality? That's why we recommend, if the event does not look like a seizure, don't do the EEG, because it will be sometimes confusing to some doctor. 1% of the people, they will have abnormal electrical discharge that I don't need to treat them if they are not having a seizure. I also finally do expect to tell me when we are going to stop the medication and how we are going to stop the medication, and this is usually 2 years from the last seizure. In general, we're not talking specifically about each different kind of seizure, because there's too many kind of seizure. And also I would expect to have at least a major side effect explained to me about the medication. For example, lamotrigine or Lamictal rash is very important to be explained. Trileptal rash is very important to look for it. Kepra, abnormal behavioral or depression or psychiatric problem, and so on. Each seizure medication has its own side effect. I think this is in general what you should expect from the doctor when you or the child when you visit for an episode that looks like a seizure. Thank you very much for watching, and have a good day, and please wait for us for more and more episodes about diseases in child neurology field. Thank you very much.